Yes, now we are in live, sir. Yes.
Yes, thank you.
Yeah. Just good afternoon, everybody. First of all, I thank my heartful gratitude, my thank to Professor Datuk sir for accepting our invitation for this kind of session, online webinar. So it is, I think so, I hope so. It is very much helpful to our students. Sir has experienced person, so he can share his experience, ideas, and suggestions to our students. So it may nourish the students in their future life. So I request to Miss Shanti Priya, Assistant Professor in Pharmaceutical Department in St. Mary's College of Pharmacy. So she will give short biodata to our students. So can you proceed, Shanti Priya?
Yes, sir. Hello. Oh, very good
Yes.
evening. Hello. Very good afternoon to one and all. So this is Shanti Priya on behalf of St. Mary's College of Pharmacy, St. Mary's Group of Institutions, Guntur. I coordinately invite to international webinar on topic is International Webinar on Emerging Patient Responsibility, Bearing Roles in Hospital and Clinical Pharmacy for Pharmacists. I'm very happy to introduce today's eminent speaker and dynamic personality, Professor Datuk Dr. Allan Mathews. So, Sir was presently worked as Quest International University, Perak University. So, Sir was completed B.Pharm in 1976 from University USM, and next up MSc Clinical Pharmacy, Manchester, UK in 1986, and next up PhD completed in 1999. PhD Operations Management completed in 2008, and next administrative responsibility, and next Dean and Faculty of Pharmacy, West International University, Perak. And Sir has membership in professional organizations in Registered Pharmacists, Pharmacy Board, Malaysia, and Life Member Malaysian Pharmaceutical Society, and Life Member Sabah Pharmaceutical Society, and Member Institute of Quality Malaysia. Sir has hospital pharmacy in clinical pharmacy, 10 years experience, and production and quality control of pharmaceuticals in 7 years experience, and pharmaceutical operations, pharmaceutical industry in 22 years experience, academic teaching experience in 11 years. So Sir has published many international and national publications and presentations at national and international conferences. So during total in teaching experience 11 years, so Sir has teaching interests in clinical pharmacy, hospital pharmacy, pharmaceutical management, in pharmacokinetics and pharmacy practice, pharmaceutical quality assurance. So thank you, sir. Thank you for accepting our invitation to ignite the students with your knowledge. So now I request to Professor Datuk Dr. Allan Mathews Garu, please start your eminent section, sir. Thank you, sir.
Thank you very much, MC and all participants. First of all, I would like to thank Dr. P. Rao, the principal of St. Mary's College of Pharmacy, for giving me this opportunity to share with you all my insights into hospital and clinical pharmacy. Greetings from the Quest International University in Malaysia. My name is Allan Mathews, and I'm the Dean of the Faculty of Pharmacy at the university. Our faculty's logo is shown on the screen there, and it embraces all the various aspects of pharmacy practice. Our tagline is real-world holistic pharmacy education, and we have embedded experiential learning from year one of the program. And so from year one, every student will get to experience real patients management. I'm also glad to tell you all that our program, the Bachelor of Pharmacy Honours Program, is given the excellent status by the Malaysian Qualifications Agency and the Pharmacy Board of Malaysia. Today, I would like to discuss with you all the emerging direct patient responsibility bearing roles in hospital and clinical pharmacy for pharmacists. Mainly focusing a lot of things what's happening in Malaysia, but also giving you an insight of what's happening in the other parts of the world. Let me take you back 1,700 years, where we see the pharmacist on your left-hand side and the physician on your right-hand side. The physician is examining the patient and describing the signs and symptoms, and the pharmacist, understanding signs and symptoms and disease states, is actually preparing a medication to treat the condition being described. So this could be one of the earliest aspects of direct patient-pharmacist involvement. And this was 1,700 years ago. However, along the way, the pharmacist retreated to the pharmacy and waited for prescription to come, and the prescription had all the ingredients there needed for the pharmacist to prepare the medicine. So the pharmacist virtually retreated away from the patient. However, with the advent of the Industrial Revolution, which brought about mass production of medicines in all forms of dosage forms, necessitated the pharmacy profession to rethink, and slowly the move back to nearer and nearer to the patient took place, starting from the United States of America in the 50s with the advent of clinical pharmacy. Now, in order for the profession to progress further, there was a need for a philosophy of pharmacy practice, which was not in existence in that context. And this came about with the advent of pharmaceutical care, which is a practice in which the practitioner takes responsibility for a patient's drug-related needs and is held accountable for this commitment. The two key words there, responsibility bearing, and when the pharmacist acts on the patient needs where drugs are concerned, and he acts on it, he's accountable for this commitment. Pharmaceutical care was introduced by two persons in the United States, Stapler and Trent, and they defined pharmaceutical care as the responsible provision of drug therapy for the purpose of achieving definite outcomes that improve a patient's quality of life. So again, the key terms is responsible. That means the pharmacist take responsibility for the drug therapy and to ensure that definite outcomes are achieved. In 1998, again from the United States, they noted that pharmaceutical care is patient-centered. and underlines that the pharmacist is responsible for the patient's drug therapy. In 1999, when I was working as a clinical pharmacist in a general hospital and setting up clinical pharmacy services in the hospital, and I was doing my PhD in clinical pharmacy, I came up with this model which actually embraces the roles of the medical doctor and the pharmacist within the healthcare system. Long before that, the medical doctor was the center of care. Everything revolves around the medical doctor. But now, it is the patient who is in the center of care, and various professionals provide care to the patient. So where the medical doctor is concerned, he takes care of the medical care, and the pharmacist take care of pharmaceutical care. But since it's all about medicines, there is a need for the medical doctor to communicate continuously with the pharmacist and the pharmacist with the medical doctor. Where medical care is concerned, it covers diagnosis, which is the realm of medical doctors, the expertise of medical doctors, although the pharmacists of today have got extensive training in disease states, in signs and symptoms. The doctor is also responsible for the prescription, although more and more pharmacists are also involved in when a prescription is written. Where pharmacists are concerned, we are now looking after pharmaceutical care. We are experts in medicines, and we are also experts in management of the patient when the patient is on medicines or medicine management. Dispensing of fundamental role remains. We ensure the right medicine for the right patient to be taken at the right time and ensuring there's nothing wrong with the prescription. This remains within the pharmacist's role. But more and more, pharmacists are involved in pharmacotherapeutic outcome management. And this is what is the major evolving role worldwide. And for the first time, we see for the last 10 years or so, pharmacists are being given prescribing rights. The old notion of doctors prescribing and pharmacists dispensing, following what is written in the prescription, is slowly becoming outdated. And prescribing rights are also given to pharmacists. I'll dwell on this a bit more later. I've got two types of strategies here. One is the red ocean strategy and the blue ocean strategy. What I'm trying to say is pharmacists should focus on the blue ocean strategy and not so much on the diagnosis and the prescription. Now, is there a difference between hospital pharmacy and clinical pharmacy? I would like, for the purpose of my talk, to differentiate the two by this way. That is, in hospital pharmacy, there's no direct patient activities. There could be some indirect, but there's no direct patient activities. Whereas for clinical pharmacy, where there is direct patient pharmacist involvement. Later on, we'll see whether clinical pharmacy can be practiced outside the hospital environment or not. So in hospital pharmacy, when our students are sent for internship in the hospital, they cover things like drug information service, outpatient dispensing over the counter, store and stock management, drug distribution, and compounding. So the major aspect here is that pharmacists as providers of products under hospital pharmacy practice. So let's look at clinical pharmacy now. What is clinical pharmacy? And I've listed the clinical pharmacy services where there's direct pharmacist patient interaction and therapeutic drug monitoring or clinical pharmacokinetic service, where we focus on the drug levels and managing patients based on the drug levels. We talk about oncology pharmacy service, cytotoxic drug reconstitution and patient management, total parenteral nutrition, compounding and patient management. I'll be talking on each of these in greater details later. And there are now medication therapy adherence or management clinics established worldwide, I think now, managed by pharmacists. And there are other inpatient clinical pharmacy services. So here, what's happening is the pharmacists are providers of care. Remember, under hospital pharmacy, the list of activities I mentioned as pharmacists as providers of products. But in clinical pharmacy, pharmacists has become providers of care. Let me go a bit more details into therapeutic drug monitoring. And there are two components here. One is the drug content analysis in blood and the clinical interpretation, recommendation, and management. I started the service way back in the 80s, one of the first hospitals in Malaysia to start a therapeutic drug monitoring service. And at that time, we managed the complete aspect of a TDM. Patient selection, and further to that, now TDM is virtually a standard service in all hospitals in Malaysia. So there's patient selection, mostly done by the pharmacists, or doctors can be also involved. Clerking of the case by the pharmacist, sampling time determination is done by the pharmacist. Drug analysis, when I started it, was done by the pharmacy department, but in Malaysia it has been centralized into the lab. Once the results come out, only the pharmacists have the in-depth knowledge to do clinical pharmacokinetic interpretation. Then the recommendation is sent to the doctor. But however, to be really total patient management by clinical pharmacists, which I was able to achieve my time, where you're able to stop the treatment, start the treatment, order for laboratory indices or laboratory tests in order to manage the patient. This would be the ultimate where pharmacists should aim for, including taking of samples, blood samples. We should be trained to be able to do that. In total parenteral nutrition, again, there are two components. One is compounding and one is clinical management. So in any of these surveys, if you're only doing the non-clinical component, say for example, like compounding, to my mind, that's not clinical pharmacy because you're just doing compounding. If you only involve with the patient, then it becomes a clinical pharmacy service. Again, I was fortunate enough after I returned from the UK to start the first DipM service in a general hospital in Malaysia. And when the service was first started, we got the gastroenterologist into the service and the pediatrician into the service. The pediatrician was really taken in when he saw the recovery time of pediatric patients. So in TDM, there's patient selection. Pharmacists will be involved in the patient selection. Then the pharmacist can be also involved in the decision of the formula, the nutrition formula that need to be compounded. And of course, this compounding is done under controlled conditions. And the product is sent to the ward for administration. And since it's total parenteral nutrition, administration is normally by the central vein. However, we must strive for total patient management by the clinical pharmacist. And I was fortunate to be able to do that, including ordering for laboratory tests, including changing of the nutrition formula. And so we must eventually, as pharmacists, take over total management. Of course, with this comes responsibility, and with this comes accountability. In oncology pharmacy service, again, there are two components: just the drug reconstitution based on prescription and the clinical management. Again, I must emphasize, if we are only talking about cytotoxic drug reconstitution, that to me is not clinical pharmacy. That to me is just a compounding in the pharmacy, according to a prescription received. Unless you are involved in the clinical management of the cancer patients, then it's called a clinical pharmacy service. So the reconstitution surely is done according to prescription. It is compounded, reconstituted in the pharmacy. You need specialized labs to do that. The product is sent to the ward for administration. But again, we must move towards total patient management by the clinical pharmacists. Inpatient services are now well established as well. And in actual fact, there are full-time pharmacists in most of the hospitals in Malaysia. And the good thing is, this presence of pharmacists is requested by the physicians themselves. What do? They identify patients for TDM and TPM. They carry out bedside patient counseling. They identify patients which has got medication-related problems and issues and how to manage them, appropriateness of dosage regimen, participation in the ward rounds when there's a grand ward round with a specialist and so on. They're involved in IV admixture service. And in future, we should also be involved in the administration of drugs. This is already happening in many Western countries. Administration of drugs patients are already involved in. It is an irony if we learn everything about the medicine, the formulation, the production, the use, and so forth, yet we are not empowered to administer drugs. We need to eventually take over this role as well of administration of drugs. Medication therapy adherence or management clinics. This is where pharmacists are involved in outcome management of medicines. And this is also very well established in Malaysia. We have 15 clinics managed by pharmacists. And of course, management clinics are worldwide as well. I'm sure it is also available in India. And the patients are referred to the clinics by the doctors. And these are the range of clinics which are now being run by pharmacists, yeah? Diabetes, stroke, hypertension, skin, HIV, anticoagulant, nephrology, thalassemia, heart failure, hepatitis, respiratory, geriatric, rheumatology, hemophilia, and pain. So 15 clinics are managed by pharmacists. They manage the patients from designated clinics. And the main activities within these clinics are compliance management, proper usage of the medication, dosage adjustment under protocol. For example, in anticoagulant clinic, the full management of the patients are carried out by pharmacists, recommendation for changes in medication, and therapeutic outcome management. So these are the 15 clinics that pharmacists are involved in. These are purely clinical pharmacy services because there's direct patient-pharmacist interaction. Internationally, I touch very quickly on internationally what's happening. One of the major things which has happened about 13, 14 years ago is the UK passing laws to allow pharmacists to prescribe independently and autonomously for any condition within their clinical competence. Now, this is law within the UK setting. Other major change which has taken place in UK is that under the National Health Scheme, and the GP settings, there is a pharmacist there in addition to the medical doctor. And when a patient comes, the patient is determined whether it is a disease issue, and then the patient will see the doctor, or it is a medication issue, and then the pharmacist will see the patient. As you all may know, vaccination in the UK and immunization, 98% are carried out by pharmacists. And now they are being promoted as first call for patients. That means the government is promoting, see your pharmacist first. In Canada, the same thing, they have independent prescribing as well as drug administration, including IM injections. In Australia and New Zealand, medicine management is the norm. And I was fortunate enough to follow one clinical pharmacist who did medicine management. The patient was referred by the medical doctor. So I asked my friend, the clinical pharmacist, why should a doctor refer a patient to you? And then the pharmacist replied, the doctor gets paid to refer the patient. So I followed my pharmacist friend to the patient's house to do medicine management. Took him about 45 minutes. And then he wrote a report back to the doctor with his recommendations. And I asked him, do you also get paid for doing this report? He said he gets paid exactly the same amount the doctor gets paid. And I asked him another question. You have given him recommendation. Is he obliged to follow your recommendation? His reply was, there's a legal implication here. If I recommend something, say for example, this drug, please change it to another drug because it is causing some side effects. And if the doctor do not follow, and if something happens to the patient, the doctor is legally liable. So these are the moves which has happened in Australia and New Zealand. And there's clinical intervention or prescription, and they get paid for that, and they got prescribing rights. The key thing which I want to share with you all, the major difference happening now is that pharmacists are being remunerated for their services, not for the moving of products. In Thailand, I was fortunate to visit Thailand a couple of years ago. All pharmacists graduate with a PharmD 6-year program. The medical program is also 6 years. The dental program is also 6 years. And they are empowered to do generic substitution. They can carry out medical therapy clinics in outpatients. They do medicine management by pharmacists. After diagnosis is done, they can carry on with medicine management. I had a look at clinical pharmacy in India, and I saw this article in Science Direct in 2016, Pharmacy Practice in India. It stated that the neglected role of clinical pharmacy has started to undergo promising changes, enhancing the profile of pharmacists and enabling them to be an integral part of the healthcare system. So the move has already started to take place in India as well. Candidates with Bachelor of Pharmacy or Masters of Pharmacy are considered to be industry orientated. But now with the PharmD program, which started in 2008, the article noted emphasis is given to clinical and patient-oriented aspect of the pharmacy profession. So changes are also have started in India as well. However, the next move should be specialization in clinical pharmacy. In Malaysia, pharmacists with a Master of Pharmacy in Clinical Pharmacy, normally a 1 to 2 year postgraduate course, or a US Board Certified Pharmaceutical Specialist, BCPS. They are available already in the Malaysian context. However, these specialization qualifications are not recognized as specialists by the Malaysian authorities. The main reason being, medical and dental specialists in Malaysia need 4 years of post-basic degree to be qualified. And hence, we at the university is looking into how to create a 4 years post-basic degree to obtain a Doctor of Clinical Pharmacy to be a clinical pharmacist specialist. In developing countries, including Singapore, specialization is already in place, including specialist register. So the plan is the pharmacists who have got a first degree in Bachelor of Pharmacy and becoming a registered pharmacist after 5 years of training and degree. In Quest International University, focus is actually, this degree is actually a generalist, and the pharmacist can work anywhere in hospital, clinical, industrial, and community. We do not focus on any of one particular area of practice. And with 2 years of clinical pharmacy experience, this can go on to a 4-year Doctor of Clinical Pharmacy, which will be practice-based. Subsequent to that, they can subspecialize into subject matter experts, undergo residency, and subspecialize into these areas, taking a number of years. So my question just now was, is clinical pharmacy only for the hospital setting? I do not think so. As long as any practice, including community pharmacy, where there is patient-pharmacist interaction, it is clinical pharmacy. In actual fact, the Malaysian laws empowers our community pharmacists to prescribe and medicine manage a large number of controlled medicine without a doctor's prescription. In Thailand, pharmacists are empowered to manage once diagnosis is carried out. In the UK, as I mentioned, vaccination, immunization, 99% carried out by pharmacists. They got prescribing rights. They got GP pharmacists now. And the NHS promotes community pharmacists as first call. In Australia, as I mentioned, they do medicine review management, clinical intervention. In the Philippines, they're moving towards clinical practice. Hence, clinical pharmacy can be practiced both in the hospital and in the community pharmacy. However, remuneration for services are provided. This is very critical, and not for movement of products. My last slide here is really looking into what the World Health Organization and the International Pharmaceutical Federation, they want the pharmacist to be. And it's pointing towards independent practice. We're talking about a decision maker. You make decision when you medicine manage. You're talking about managing a patient. You're talking about lifelong learning. You're talking about a good communicator. Once you are interacting with a patient, you need to be a good communicator. You need to be a caregiver, and you need to lead. So this is the focus that we are trying to create our graduates from Quest International University, trying to focus on these main areas. And hopefully with that, in the long run, we'll create graduates who will move towards independent practice. Thank you very much and for your kind attention, and I'll be most welcome to answer any questions that you may have. Thank you once again.
So thank you very much, sir.
Thank you.
Thank you very much, sir, for your excellent session, sir. So you have differentiate the pharmacist and clinical pharmacist also. And
Yes.
sir, yes, sir, we have one question, sir. That 15
Yes.
clinics are managed by clinical pharmacists, sir. 15 clinics. You mentioned one slide, sir.
Clinical pharmacists within clinics.
Yeah, 15 clinics.
Yes. Probably the best example we can have is what is happening in the UK. As you know, they have a national health scheme, and patients are registered with the with a particular clinic.
Yes.
Previously, when I was there in the late 80s, you only have a doctor within that setting. But
Yes,
now
sir.
they have a GP pharmacist within the setting. And as I mentioned, when the
Yes,
patient
sir.
comes,
Yes, sir.
there'll be
Yes.
somebody to determine whether it's a disease condition to see the doctor, or is it a medication problem to see the pharmacist.
Yes, yes, sir. And also, you explained very well, sir. Based upon different countries like Australia, Malaysia, Canada, Thailand, Singapore. So, you explained role of pharmacist in different countries. And
Yes.
also, you suggested one, sir, after completion of B.Pharm, 5 years, 4+1.
Yes.
So
Yes.
better if you choose any M.Pharm clinical pharmacy, so it will give a better future like that. So we noticed it like that. So because and also one thing, sir, here.
Yes.
Can I ask one more question, sir?
Sure, please.
Yes, sir. You said that the drug content analysis in blood.
Yes.
Drug content analysis in blood.
Yes.
That clinically interpretation by that means this clinical pharmacy. So suppose I studied clinical pharmacy, sir, M.Pharm clinical pharmacy. So
Yes.
I can analyze the drug content in blood, sir.
Yeah. Okay. Very good question. This is we are measuring the concentration of the drug for certain drugs in the blood, yeah, and
Yes,
for
sir.
the purpose of adjusting the dosage to achieve a certain drug concentration level for certain drugs, as you may know. And so when I started the service at that time, and until recently also for the general hospital where I'm now linked to with our university, that analysis of the content, the concentration of the drug was carried out by the pharmacy department. But
Yes.
now it has been concentrated within the laboratory services to ensure quality and so forth. Yeah.
Yes, sir.
Yes.
Thank you very much, sir. And also, sir, here you have given a word that accountability. On
Yes.
what basis that clinical pharmacist he has given accountability, sir?
So basically, when you manage the service fully,
Yes, sir.
that means you're fully responsible for whatever actions you take. Say, for example, we say, okay, stop the drug treatment for the time being because the level is within the toxic range.
Yes.
So you are actually taking a decision to stop the treatment.
Yes.
And in so doing, you have to be accountable for that particular decision you have taken.
Oh.
So
Yes, sir.
responsibility bearing comes with accountability.
Yes, sir. So in that case, what is the difference between a doctor and a clinical pharmacist, sir?
So as I mentioned, the clinical pharmacist will look into medication management.
Yes, sir.
Managing the patient on the medication. The clinical pharmacist will not be involved in the diagnosis of the aspect. The diagnosis will be the doctor's side.
Yes,
and
sir.
after the diagnosis, the pharmacist takes over managing the medication aspect of it.
Yes, sir. And what is you have mentioned different types of countries, sir, like Australia, Canada, Thailand, Malaysia, Singapore.
Yes.
So in these countries,
Yes.
What is the country giving importance to the pharmacist, sir?
Yeah, I think very good question. Huh? And the question comes, why are pharmacists becoming more and more involved clinically? What has happened is this. What has happened is this. A lot of studies have been carried out in the Western world on the role of the pharmacist. And they found out two main aspects. One is when the pharmacist is involved in outcome management, the patient mortality and morbidity goes down, and hospitalization also goes down. And the studies show that with the pharmacist involvement, the government saves money.
Yes.
So with
Government
these two, the government saves money. And you and I know, if we can show the government, if you involve the pharmacist, you're going to save you money, then the policy makers become interested. That is the route the Western world have taken for pharmacy practice. And they show by studies, hey, involve the pharmacist. If you involve the pharmacist, better outcomes, lesser hospitalization.
Better outcome, lesser hospital. Yeah.
Yes. And with that, the policy makers, they say, hey, why not? So now the government is enacting laws and regulation to get the involvement of the pharmacist. So we may think further, is the doctors happy about this? It's not as smooth sailing. Even in the UK, it's not smooth sailing. Lately, they came out with a regulation allowing pharmacists to do generic substitution. The doctors was making a bit of noise, but the government still passed the law. Because who is the best professional to talk about medicine from the time of formulation to the time of usage? Is only the pharmacist has got the most intense knowledge in all of these areas.
Yes, sir. Yes, sir. So compare these countries, sir. Compare these countries.
Yes.
I heard the news about the Canada is giving importance to the healthcare system, and much more money they are spending through government. Like that, I heard that. So it is correct, sir.
That's correct. Actually, Canada is also moving very fast ahead in the utilization of pharmacy skills and knowledge. Even like as I mentioned, they have gone into administration of drugs. Pharmacists are empowered to give administration of drugs. Yeah.
Yes, sir.
Yeah.
Sir. Yes, sir. Yes, sir. One student asking question, sir.
Yes. Yes.
Yes. During the COVID-19 response, telecare in pharmacy is correct or not?
In the COVID-19 response, say it again.
Telecare medicine. Telemedicine.
So in the
telemedicine.
The involvement of the pharmacy in the COVID-19.
So telemedicine is involvement.
Telemedicine.
Yes, sir.
Yes. I think the involvement of the pharmacists under COVID-19, many different places, I think the involvement level is different. Even I think the UK, New Zealand, America, they allowed the pharmacists to do COVID-19 testing using the test kit.
Yes,
but in Malaysia and so on, I think it was mainly to do with supply, ensuring supply. And especially of PPE, personal protection equipment. But so there was a different aspects of involvement of the pharmacists. Telemedicine and telepharmacy, of course, it is already happening in countries like Australia and so on. But in countries like Malaysia, I think it's still not there so much yet.
Not so here.
Yeah.
But without diagnosis the patient, telemedicine may give worst results, sir.
Telemedicine for diagnosis.
Yeah, without diagnosis the patient.
Yes.
If telemedicine, it gives negative results, no?
Yeah, if I didn't get your question too clearly, I was breaking up just now. Can you please repeat?
Sir, without diagnosis the patient.
Yes.
Telemedicine is correct, sir.
Without diagnosis of the patient.
Telemedicine.
Telemedicine, yeah.
Is it correct or not?
Oh, you mean diagnosing via telemedicine?
Yeah.
I think this. I'm not too deep in, because diagnosis is definitely under the realm of the medical doctor.
Yes.
And of course, telemedicine in terms of a sharing of certain type of diagnostic skills like X-rays and so on is, I think, it's already happening with the resolution becoming so much better now. You can actually read X-rays via online and so forth.
Yes.
But having said that, I've read something about telepharmacy,
Yes.
especially for those areas in which rural areas where there may not be pharmacies, yet they are able to provide telepharmacy to patients via video link and internet link and so on. That is also already happening in some countries.
Student, any questions, please, from faculty side? Any questions? If you want to ask the questions, just type in live chat. So
yes, I can see the live chat. Yes, I'm most welcome. I'll try to answer some questions if possible.
Yes, sir. Sir, one question, sir.
Yes.
Yes, that live chat. Roll off. You see the live chat, sir?
I can see, yeah, but no questions come through yet.
Yes, a role of clinical pharmacist in rural areas.
I don't see the question here. Live private chat or live comments, is it, or no? Oh yeah, okay, I can see it now. Let me see. Go any question? There was. Hang on.
It's going. It is going, sir. Role of clinical pharmacist in rural areas, sir.
Clinical pharmacist in rural area.
Yes, sir.
Yeah.
Clinical pharmacist. Yes.
Clinical pharmacist in the rural area. Yes.
Yeah.
You see, that's a very interesting question. You know, Dr. P.V. Rao. You know why? Because in some countries, in the rural areas where they don't even have medical doctors, they rely a lot on the pharmacists for treatment and of ailments and so on. You know, that is also happening in some countries. I'm trying to see if there's any particular question. I'm looking at there are just thank you comments here so far. Can I ask Dr. P. Rao, how is the clinical pharmacy education in St. Mary's here?
Yeah. We have only diploma in pharmacy, bachelor of pharmacy, B.Pharm pharmacology, sir. So
Yes.
in that we have one subject only, clinical pharmacy, and also for final year student B.Pharm degree final year we have one clinical pharmacy, sir. We don't have any M.Pharm clinical pharmacy, sir. So based upon your slides, so I can think of that M.Pharm clinical pharmacy also now, because the clinical pharmacy is very good importance in the abroad. So you have given that a nice presentation, sir.
Thank you. And of course, I'll be most happy to share how we carry out our clinical pharmacy program.
Yes, sir.
Mainly in the 3rd and 4th years.
4th years, yes, sir.
3rd and 4th years.
Yes.
Yes, and also our teaching of clinical pharmacy is carried out by practitioners from the general hospital.
Oh, yeah, it is. Yes. So that time only it gives positive results, and we can get the positive feedback from the students also, sir.
Exactly, exactly. And then they go for 8 weeks of internship during the 4-year period. They go for 8 weeks of internship within the hospital setting.
Yes.
And then yes. And as I mentioned, I think we are one of the very few universities, colleges of pharmacy in the country. I think no other university where the first-year students get the opportunity to interact with patients from the first year.
Yes, sir. Yes. So after completion of degree, sir, in my college, suppose some of the students, they are trying for abroad. So after completion of B.Pharmacy, they can get a chance, a seat in your Quest International University in M.Pharm clinical pharmacy, sir.
I mean, after the completion of the Bachelor of Pharmacy program in Quest, then they do 1 year of housemanship to get registered as a registered pharmacist, so 5 years training. They can go anywhere. We have got master's program in Malaysia. They can go anywhere in the world to do a master's program, or even some of them go to the United States to do the PharmD program as well. They do, yeah. So yeah, they can do that. Yes.
Yes, sir.
We at the moment we have got masters and PhD by research into clinical pharmacy as well, and we do have some students working on that as well.
So what is the research is going on, sir, about this clinical pharmacy?
Yes, the research actually goes on. We have students now from those who are practicing pharmacists in the general hospital who register with us to do the masters by research into certain aspects of pharmacy practice in the hospital. Say, for example, in TPN or in TDM, in outpatient pharmacy service and so forth. Yeah.
One student is asking, sir, in the live chat, after completion of B.Pharm, which job is right, sir?
Which job? Sorry?
Which job is correct? And whether clinical pharmacy or like that is asked.
Very good question, yeah. As I mentioned, our program prepares graduates for the 3 areas of practice. Industrial pharmacy, community pharmacy, and hospital clinical pharmacy. And of course, for industry pharmacy, about 10% of pharmacy graduates gets into the industry. And industry is so important in the sense that if there's no industry, there's no medicines. And in actual fact, in Malaysia, the industry pay the best. Industrial pharmacy pay in terms of remuneration, they pay the best in terms of remuneration. Followed by community pharmacy, also very much in demand in Malaysia, community pharmacy. In Malaysia, only a registered pharmacist with a Bachelor of Pharmacy degree can open and operate a community pharmacy. We do have diploma in pharmacy graduates in Malaysia, but they are not entitled to run a community pharmacy in Malaysia. Only those with a degree can do so. And of course, hospital and clinical pharmacy. About 55% end up in the hospital, about 30% in the community, and about 10% in industry. So it depends on what is your passion, which particular job is your passion, whether you want industry, hospital, clinical, or community. Definitely depend on your passion. Of course, industry pays the best, I think.
Sir, you have a lot of experience in the field of pharmacy.
Yes.
In the field of pharmacy, but you are giving a lecture very slow, neat, awesome, sir. So it is very understandable. So to any student, even though if the B.Pharm students comes from Telugu medium, he can understand very easily. How it is possible, sir? You are very, very attractive and awesome explanation, sir. How it is possible, sir?
Dr. P. Thanks a lot for that compliment. But probably I'm one of the lucky ones, because when I came out from the university, at that time, production of pharmaceuticals, including IV fluids, was done in the hospital, and I was involved in the production of IV fluids as well. You know, and so I was a lucky one at that particular generation, where the industry was not yet in full swing, and we had to make everything within the hospital. So I was involved in production and quality control of medicines. And after some time, I left the hospital and clinical environment, and I went into the industry for mainly on good distribution practice. Good distribution practice. I was there for about 22 years, so all about GMP practice and what is this on storage, ISO, and so forth. Then I got interested in academia about 10, 11 years ago. Then I slowly moved into academia as well. So I was one of the fortunate ones to be able to go into different fields of practice. And now I come into the academic field, and hopefully I'm able to share this type of real world, real life type of experiences with my students, you know. And so I'm one of the fortunate ones, I think, Dr. P. Yeah.
One more question, sir, from student. You can see in live chat also.
Yes.
Madhu Deepika.
Yes.
Natural therapies are more powerful than chemicals.
Natural. I saw that. Yeah. Natural therapies are more powerful than this chemically involved medicine. Then why is this chemically used are more popular than the natural ones? Now, what I must say is there is now a sure role for medicines, herbal medicines, and what is this, natural products and so on. Definitely there's a role there. The major difference, as we know from the scientific world, is that for the Western type of medicine, the chemicals that we are talking about here, extracted chemicals, they have somehow been tested extensively and statistically been able to show that it can bring what type of benefits. Whereas natural therapies are a lot toward testimony based. And but having said that, also more and more of these natural therapies are also undergoing rigorous studies and testing, and their roles more and more are being come to the forefront. In Malaysia, we have actually set up, it's officially recognized of TCM, complementary medicines, okay? And so in hospitals, they have divisions now where they use natural therapies as well as part of overall holistic management of patients. So there is a role to play, but the major difference is the problem of how can we statistically show that these natural therapies have a benefit in treatment-wise. That is the major issue, I think, here. And more and more studies are being carried out, and I'm sure natural therapies will also play a bigger and bigger role in patient management. Hopefully, I've answered that question to your
yes,
your
yes,
question.
sir.
Yeah.
Yes, sir. We got, sir. One more question, sir. That Krupa Karuna and one Anand Babu is asking question. So,
Yes.
which one has best scope, hospital pharmacy or clinical pharmacy?
Which is the better scope?
For hospital pharmacy and clinical pharmacy.
Oh, okay. Normally we do not. Normally we don't segregate or separate the two. And within the hospital environment, when the pharmacists go and work in the hospital environment, I'm talking about Malaysian context, they can be placed either in the clinical pharmacy side or normal hospital services, the traditional, I use the word traditional hospital services like outpatient, drug information service, and so on. They could be rotated to different type of services. But having also said that, I'm reading more and more and more that eventually for pharmacy to really survive in the long run, of course, industrial pharmacy will never go away. You need industrial pharmacy because you need medicines. But in the hospital environment, clinical pharmacy environment, community environment, more and more it will move towards patient management. You know, so clinical pharmacy is, I think, in the long term, will be the role where pharmacists will play a bigger role in hospitals and community pharmacy. Having also said that, the other aspects of pharmacy practice will still remain. You're talking about outpatient dispensing, you're talking about information service, ensuring proper supply of medicines. That role will remain, but the shift is towards this type of role. And more, what's happening is that routine roles, those which are routine, activities which are very routine, are taken by diploma in pharmacy graduates. Not only in Malaysia, even in Western countries, or pharmacy technicians, they call it. These are O-level graduates with 3 years of training. After O-levels, 3 more years. I think even in India, they do have a diploma in pharmacy graduates, if I'm not mistaken. Yes, Dr.
Yes, sir.
You do, yeah. So for us here, they carry out the routine work. And then they do the decision-making roles taken over by pharmacists.
Thank you very much, sir.
Thank you.
For excellent session, sir. Already it is 3:40. You have given time 2 hours time. From 1:32 onwards, you are in line, sir. So questions are coming, but they shared through email also to Vijay Quatra. So they will answer the questions, sir. Thank you very much, sir. So we are very much happy and delightful. So we never forgot your university, sir, Quest International University, because you and Dr. Syed Atif Garu both are given excellent, wonderful session to our students. Thank you very much, sir.
Thank you so much for the opportunity. Thank you, and we hope to be able to connect further as we go forward.
Thank you, sir. Thank you, sir.
Thank you.